Meanwhile, Dr. Sagarika, please.
Okay. Blistering surprise, epithelial bullae formation post trabeculectomy, bleb massage. It is not. So trabeculectomy stands as gold standard and most frequently performed glaucoma surgery, and post-operative bleb massage is a common practice aimed at promoting aqueous flow through the newly created pathway. However, there are potential complications of bleb massage like hypotony, shallow anterior chamber, iridocorneal touch, hyphema, even suprachoroidal hemorrhage and choroidal effusion are reported. Here I will present a novel complication following trabeculectomy, that is corneal bullae formation post-trabeculectomy bleb massage. So patient is a 50-year-old female who presented with pain in her left eye from last 1 month, and on examination there was angle closure and markedly elevated intraocular pressure, 60 mm of mercury. There was posterior SNEHI and complicated cataract. So first medical management was done to decrease intraocular pressure, and surgical intervention performed. Patient underwent combined phacoemulsification and trabeculectomy under mannitol cover. On post-operative period, intraocular pressure remained high, 38 mm of mercury, with a flat congested bleb along with fibrin reaction in the pupillary area. So bleb massage was done to administer enhanced outflow through bleb, and decrease in intraocular pressure from 38 mm of mercury to 22 mm of mercury noted post massage, but there were the bleb was flat and there were multiple well-defined corneal bullae emerged near the superior limbal area near the bleb. So further massage was withheld and releasable sutures were removed, leading to bleb formation, and there was subsequent decline of IOP in to 14 mm of mercury. Another patient was a 60-year-old female patient who presented with uncontrolled IOP of 50 mm of mercury. There was history of acute left eye congestion 5 months prior, which resolved after use of unspecified medications. On examinations, there were pigmented KPs, posterior SNEHI, complicated cataract. Patient was diagnosed as secondary angle closure glaucoma and underwent combined trabeculectomy and phacoemulsification under steroid cover. Initially, IOP was controlled 8 mm of mercury, although there was flat bleb. And on post-op day 7, IOP surged to 40 mm of mercury. We removed the releasable suture, but there was no formation of bleb, and the bleb massage was given. And again, in this patient also, multiple bullae emerged near superior limbal area proximal to the bleb. So further massage was withheld, and definitive management was planned with the medical management and bleb revision after resolution of fibrin and congestion. So in both of our cases, combined cataract surgery and trabeculectomy was performed in patients with complicated cataract, and intense fibrin reaction was noted in post-operative period. So our hypothesis suggests that during scleral flap creation, the dissection of the scleral flap that extended more anteriorly in the corneal plane beyond the sclerostomy. So sclerostomy was patent, but when we gave the bleb massage, so aqueous traverses through the sclerostomy, but because of the tight scleral flap sutures, it could not go in the subconjunctival space, but it found its way in the corneal plane, and there was reverse migration in between the corneal layers and formation of intracorneal cleft and bullae formation. Similar to our case, in a patient with post-glaucoma drainage device surgery, acute intracorneal cleft formation occurred after massage. And in another patient, when ocular massage, post-trabeculectomy, ocular massage was done by patient at home, and patient presented with acute ocular pain and redness, and there was corneal eye drop secondary to the ocular massage. So these cases emphasize that reduced intraocular pressure post-massage may not solely indicate bleb formation, and there may be they may potentially lead to development of intracorneal cleft. The tightly sealed scleral flap can obstruct the aqueous flow towards subconjunctival space and may lead to reverse migration between corneal layers, causing bullae formation. So timely identification of this complication is crucial, as further massage may exacerbate bullae formation and may lead to corneal eye drops. Thank you.
Thank you, Dr. Sagarika. One question.
Yes, sir.
In your first case, you did trap with releasable sutures.
Sorry, sir?
Your first case was trap with releasable suture.
Yes, sir.
So on what day you did this bleb massage? Means
Sir,
if there is any bulla, then you can remove the releasable sutures. It already released your
yes, sir. We could
tightness
have
or
done
whatever
that.
you
I did the
hypothesize.
massage first, and so there was bullae formation, and then I released the releasable suture After that, IOP decreased to 14 mm of mercury.
Later, after bullae formation. So what message will you like to
Like
give?
If there is a decrease in intraocular pressure, we should see carefully if bleb is forming or not. There may be corneal bullae formation, and if there is like fluid in between the corneal layers, so we should stop the massage.
How will you do the massage? I think, is there something to do with the massage you do? Like, in which direction, from the lower
But it
lid
doesn't
or
happen
from
in
the
every
upper lid
patient,
or
ma'am.
in between the sutures? Is there any particular way which can prevent this finding of doing the massage? Or
It may be related to the surgery,
But it is not a very common.
Yes,
even if
ma'am.
the scleral
But it
sutures
doesn't
are
happen
tight,
always.
You massage it, it doesn't go the reverse way in most of the cases. I think it also depends where you are massaging, whether through the lower lid or from the upper lid.
No, from the
And-
lower lid I do it.
Okay. So
I ask the patient to look in the down gaze from the lower lid, and under the direct observation I do the massage,
so when
and
you're
I can
doing
see
it
that.
from lower lid, so ideally it should not come
Come outside.
out. But it should go out. Not,
Yeah,
it should
and
not go-
yeah, I do massage in my patients, and also,
Okay.
but I have seen in just 2 patients I have seen
So
this
the sutures
complication.
you mean are very, very tight.
Yeah.
I think you should put, less tight sutures. Sutures should be slightly.
But in both patients, there were fibrin reaction and complicated cataract. There were, like in one patient, it was post-uveitic attack, and in another patient, acute angle closure attack in 1 month back, and then she also had complicated cataract. In both patients, there was and fibrin reaction was also noted in post-op
Basically,
period.
these fibrin reaction leads to blebitis.
Yeah.
There will be a inflammation which
In the
carry
bleb.
forward inside the bleb and other things there. But it's okay. And whenever you will find out these blebs or anything and you have did a releasable suture, then remove the suture first,
Yeah.
so that it gives passage for the drainage. If it is exactly because of the tightness of the posterior flap or the ostium flap.
In fact,
Okay.
1960s, there was an article by Treviso which talked about post-trabeculectomy, when there is a lot of fibrin, the scleral flaps tend to adhere. So there is something known as a Treviso's maneuver, where you do a direct massage on the bleb, so as to release the
Yeah.
fibrin
Yeah.
adhesions
Fibrin
between the two. So in such cases, when you have done a cataract along with a glaucoma procedure, and we have a lot of fibrinous things, a direct massage before that you can do a traversos to make sure that the drain is happening, the scleral bleb, and then you can go the traversos maneuver followed by the this thing.
Dr. Nupur is here.